Good afternoon, everybody. This is Stephanie Hall, and I am with the ESRD NCC National Coordinating Center. Thank you so much for joining us today for the ESRD NCC Professional Education Webinar event. As you know, these events are being held in partnership with the Centers for Medicare and Medicaid Services. The series of events feature guest speakers from around the country sharing how they or their organizations they are with are coping with COVID-19. Before we get started, I just wanted to let everybody know that this call is being recorded and will be posted to the NCC COVID webpage within 3 business days. Next slide. So just a little bit about what the call is about today. This is today's speaker. We have Daniel Landry. He is the chief of the Division of Nephrology with Bay State Medical Center, also medical director of inpatient dialysis and critical care nephrology, University of Massachusetts Medical School, Bay State, and he's the chair medical review board for ESRD Network of New England. The topic today will be the promising future of advanced practitioners in nephrology. And at the end of his presentation, we will have time for questions. So everybody has been muted upon entry into the event, but we do want to hear from you today. So during his presentation, if you have any questions, please submit them to us either through the Q&A or through the chat feature, and we will get to those questions at the end of his presentation. Next slide. So these calls, if you've been on them before, you know that we have different stakeholders and peers in the ESRD community who are sharing their best practices and how they're dealing and adapting to COVID-19. They will share examples and provide real-world strategies for facilities to use. And we do have these calls bi-monthly on different and varying topics. Next slide. So I'll go ahead and introduce Dr. Landry. Dr. Landry was born in Worcester, Massachusetts, and attended college at the College of the Holy Cross. Following the completion of medical school at the University of New England College of Osteopathic Medicine in Maine, he trained in internal medicine at the Naval Medical Center in Portsmouth, Virginia. After 7 years of service to the U.S. Navy, he trained to Massachusetts and performed his fellowship training in nephrology at Bay State Medical Center in Springfield. He currently serves as the chief of nephrology, as well as the director of acute inpatient dialysis and critical care nephrology at Bay State Medical Center. In addition to functioning as the medical director for the in-center and home dialysis unit at Fresenius Kidney Care East Springfield, Dr. Landry is a member of the only ESRD Seamless Care organization in New England and has been recognized for his excellence in teaching in Bay State's nephrology program. Married with a daughter, Dr. Landry enjoys trips to Maine with his family and is an avid runner. So Dr. Landry, we're going to go ahead and you have the ball, and I'll go ahead and you can go ahead and do your presentation. I believe you're muted. Okay.
Yeah, thank you. Thank you for that nice introduction. And I want to certainly thank the National Coordinating Center and CMS for having me here today. I, again, appreciate everyone being here today, certainly. Today's topic, as you can see here, might be something that I'm sure some of you are kind of questioning exactly how this all fits into the current COVID pandemic that we're managing. But I think like a lot of things throughout this past year, we've engaged in a lot of different areas to try to improve our workforce and what we do in nephrology. And lo and behold, I think we found that some of the areas we've been working on and even well before the pandemic have really met the need and really helped improve the care we give our patients throughout this. And as I was asked to give a talk today, I thought that prime in my mind was the idea of how advanced practitioners have really re-energized what we're doing in nephrology, I feel right now. Certainly have affected us personally, locally, where I work. And I really do believe that they truly are a major piece, a cornerstone of what nephrology is becoming and needs to be in the not too distant future. So with that in mind, I'll just tell you first of all that the goals or objectives for today is that we're going to talk about the challenges of the current and future nephrology workforce, and how this all fits into the current views that I have, and how I think we can actually make nephrology better. Also, we're going to describe how advanced practitioners, and forgive me, I know some of you prefer APP, but I felt for the brevity of today and everything, advanced practitioners are supporting nephrology through clinical, educational, as well as quality improvement projects. And then we are certainly going to discuss how advanced practitioners have played a major role, particularly, as I said, locally for us here, in terms of working within the COVID pandemic crisis that we've all been faced with, as well as within the healthcare delivery changes that we're experiencing and been part of now for the last several years in terms of advanced alternative payment models. So I'll start with a slide that some may find amusing. I know my wife, who's not a nephrologist, did a little bit, but at the same point, it's also a bit of a harsh reminder that nephrology isn't for everybody. Those of us that do it, I think we're passionate about it. We love it dearly. But as I want to explain today, that nephrology is not just a job for physicians. It's for a lot of different people. And as this article from 2009, and I was actually speaking to one of the authors recently. He said, Dan, I'm really sorry that I was right, but this article was really kind of hit the nail on the head in terms of what these folks were worried about nephrology was facing. And it's interesting because in 2009, if we actually take a look to our right, we'll see that in the red column of 2009 versus 7 years earlier, that actually the applicants, people involved, it's all very stable, if not reassuring numbers. Yet the authors here looked at several different factors, one of which was actually looking internally at nephrology fellowship programs and asking, are you happy? And for those of you who graduated and are moving on, are you happy? And they said, boy, we may be running into some trouble here, because as we've talked to our fellows, future and should be present, and those that have graduated, as well as people who potentially could be future fellows, like the person who's quoted here, they realized that morale was not high, and they were concerned that this was just the beginning of what was trouble to come. And sure enough, as we look ahead, they were right, unfortunately. Take a look, for instance, at how nephrology fellowship program has programs that the country have kind of gone from being a buyer's market, if you will, to really a seller's market. In other words, back in 2009, even at the time of the article I just showed you, there were 1.6 applicants for every position available throughout the country. Whereas move ahead here even just to 2016, and I'll tell you that since 2016, the numbers really haven't changed, it was 0.6 applicants for every available spot. And with time, as we saw maybe our match rates were hitting 90% mark, but actually as time has gone on, of course, we're seeing more and more unfilled positions, which is clearly a problem, particularly when you look at the fact that there's a greater need for us out there. So if we do fast forward ahead to just the last couple of years, in 2019, otherwise known as the appointment year of 2020, actually the nephrology match, again, as I mentioned, has continued to stagnate. And in terms of interest, has really just not been as high as we'd like to see it. 38% of nephrology fellowship positions have been left unfilled. And, with that in mind, I think, a not unreasonable thought would be to say, well, let's simply just close down some of these nephrology fellowships. If they're not filling, let's just, that's what we have available to us. Supply side is what we should work with. But again, at the same point, there also comes the concern that there's increasing patient demands. And there's also pressure being put on us to really improve the cost of care and the value of care that we're giving our patients. And that's something that I believe actually is, I think we can actually turn from part of the reason why fellowship applicants are down, and actually turn it into a plus for us. And I'm going to show you that in just a few. But if we actually take a look at the amount of patients over the last 20 years, essentially, who have developed, acquired, and labeled as being prevalent CKD, you'll see that the numbers are consistently growing year after year. And if you look to your left-hand side here, you'll notice that this is not just mild CKD stages here, but this is CKD stage 3, 4, as well as 5 growing. And no surprise, as we see stage 5 CKD evolving and growing, we're seeing, of course, an increased incidence of patients who are on hemodialysis as well as peritoneal dialysis. In other words, the end-stage renal disease population is absolutely growing as well. It's nice to see that, that just transplants are growing, but nevertheless, we're still seeing hemodialysis and peritoneal increasing as well. So again, we have increasing need from our patient base, and we have limitations in terms of providers who are going to be coming out of the pipeline, so to speak. And then consider the fact that from this data from the USRDS in 2018, that think about the fact that our ESRD beneficiaries take up approximately 1% of the entire Medicare population, and yet they actually take up over 7% of the total fee-for-service spending, okay? So we've known for a long time now that our patient base are ones that require very expensive care. And we know this, of course. Our patients are, as I've always said, but I think to even pretend for a minute that we know what it's like to walk in their shoes is clearly a foolish idea. When you consider the access complications they go through, the hospitalizations, the associations of complications from diabetes or high blood pressure, anemia, peripheral vascular disease, all those comorbidities. And when you look at that, we have to recognize that our patient cohort goes through a lot, and it's very expensive to care for them. So we have some reality checks here. We have some things that we have to kind of, I think, stare in the mirror, recognize as a society, as a group of nephrology workforce, that we do. I think we take pride in the fact that our expertise, our subspecialty is considered challenging academically. Our patients are challenging. It's part of, again, what I think draws a lot of us to the area. We, of course, at any one time, as I tell medical students and residents all the time, any one day we could be rounding early in the morning at the dialysis unit and then placing central line in the ICU, seeing a woman with preeclampsia, and some of us even do pediatric nephrology care. And that's before we get to our afternoon lecture at noontime and then go off to the clinic. So there's a lot that we do. I think I'm a believer that I think we should maintain those things and actually work to improve them. But it's a lot, and I think it's intimidating for some of our medical residents and people who want to go in to advance their training. The work schedule, as I mentioned, is what it is, but we're fairly busy as things go. We're certainly a group of people when we're on call, right? We're oftentimes do end up in the hospital in the middle of the night and not just taking phone calls from home. There is some data over the last decade or more of evidence of declining wages in different parts of the country in particular, but as a whole, as a specialty, nephrology is faced with that challenge. And then part of what I see is actually an opportunity, but also admittedly is something that in the midst of declining wages and declining workforce, a lot of nephrologists have said, now you want me to kind of move on from the typical fee-for-service model and start being placed into some of these advanced alternative payment models where we're being looked at from the perspective of, are we giving high value quality care? In other words, right, can we help our patients do better, have better outcomes, and do so at less cost, hopefully. And that even as recently as just this past January with the ESRD treatment choices model now involves 30% of nephrology practices throughout the country. And as Stephanie mentioned early on, I've been actually part of a seamless care organization where we've been involved in similar efforts over the last 5 years. So, I think we, to a certain degree, need to kind of be willing and able to embrace value-based care. And but in order to do that, obviously, we're talking about change, and I think a lot of people, understandably, are not crazy about change. And particularly when you throw a pandemic in the middle of all this, it just further adds to that challenge. But if you do look at advanced alternative payment models, you can see why there is opportunity here. And this comes from a group that was published back in 2016 in looking at cost of care. And while this might be a surprise to some people on here, but the typical cost for an ESRD patient in our part of New England is about $85,000 a year for all healthcare expenses. So what this author presented, which was not for New England, is actually pretty much spot on to what we see right now. And we've recognized too, of course, that in order to provide care to patients, if they were to say receive peritoneal dialysis, it's actually much less expensive. Transplantation, once you get past that first year in particular, absolutely much less expensive to healthcare in general. And of course, if we can keep our patients with advanced CKD from progressing in the first place to any of these other categories, we can also help save a lot of money, as well as also help improve, hopefully, the quality of life of our patients. So this is really, if you look at it, this kind of, in a nutshell, sums up what the Advancing American Kidney Health model is all about. It's about trying to refocus efforts to move away from in-center hemodialysis, get our patients on peritoneal dialysis, home hemodialysis, get them transplanted, as well as try to really refocus our efforts on the advanced CKD population and either try to help keep them in that place or hopefully try to transition them very rapidly over to transplant. So as I'm trying to allude to, and I hope at the end of this talk people will feel more hope rather than dismay or anything else, but I think there are actually a lot of reasons for hope. In that with these advanced alternative payment models, it's an open landscape. There's an open opportunity for us to actually make change. And here the federal government's actually saying to a lot of us, look, we're going to give you a budget or different things to work with, but we're going to allow you to kind of make your decisions and figure out what works best for your patients. And hopefully through networks like where we are today and other places, we can share these, what we've learned and help other people. We're moving away from a fee-for-service mentality. It's been brought up for a long time now, but that being said, we're here now, and we really have been here for a period of time. And with that in mind, I think nephrology is actually the right group of people to be taking this on. But keep in mind as well that we have a history of doing this, whether it be bundled payments or things of that nature. This is what nephrology has done. We've been on the kind of the tip of the spear in terms of taking on some of these more challenges with some of the most complex patients out there. And if we take a look at what the group that I've been part of over the last 5 years or so was the comprehensive ESRD care model, otherwise known as the ESRD model, as some would just kind of refer to it as. But what's actually gone from that, what it's evolved into from the ESCO, has been into the ESRD treatment choices model, and then some voluntary models that fall under the umbrella of kidney care choice, that they refer to as kidney care first, or comprehensive kidney care contracting, CKCC models. And this talk today is not actually to go into that in any degree of detail, but it's actually a talk I gave at the ESRD network not all that long ago. And in the kidney care first model, which is something my group looks to hopefully be venturing into, as well as the CKCC model is something that's going to be starting up before long. And as I said, 30% of the country right now, nephrology-wise, is actually part of this treatment choices model. So again, people are being placed front and center to say you need to show quality and value to what you're doing. And as we're going to talk about value and quality, I think one major place where we're going to succeed is with the partnership with advanced practitioners. And it's kind of interesting. A lot of times I realize different thoughts, ideas, and people sometimes come onto the scene by accident or for reasons that maybe we would never have imagined to be the likely background. But actually, if you go back and take a look, advanced practitioners became a part of nephrology practices back in early 2000. And the major reason that happened, just happens to turn out was the fact that the monthly capitated payment system was created and evolving. And as nephrologists, in order to reap the full financial compensation, frankly, for their dialysis care, they needed to be in the dialysis units 4 times a month. And that wasn't easy, as you can imagine, for a lot of people. And they saw an opportunity to bring in advanced practitioners to kind of be their right-hand people and help them around in dialysis units. And by 2013, as you can see, 3/4 of nephrology practices in the U.S. actually were employing at least one advanced practitioner. And this data that I'm showing you here actually comes from a very, very nice study, a survey that was performed by Zuber and colleagues, and actually just published a little over a year ago, where they actually looked at over the last 8 years what were the different functions of advanced practitioners in nephrology practices. And they also went into other areas as well. They looked at compensation. They looked at how happy they were in their job in different areas. But a couple of things that I'll kind of summarize from this slide and show you here is that, of 1,088 advanced practitioners that they interviewed, 88% were involved in hemodialysis rounding, and approximately 53% of their time was spent providing dialysis care. And only 14% of their time was spent providing hospital-based care. And at the end of the day, when you take a look over this 8-9 year period, that data didn't really change much at all over this course of time. And I will say from my personal take, and I'm sure many people here on this call today would agree, that I think if we have a group of people who are doing the same thing over and over again, it's a lovely setup for burnout. And and I think that's been a concern of mine, and something I think that we've witnessed during this course of time that Erickson and Zuber and colleagues present, is that it looks to me that advanced practitioners who work in nephrology have been kind of in this merry-go-round, if you will, of running around dialysis units. And it was with that knowledge, observation, that my group and a couple of us kind of put our heads together to say, if we're going to make this work, if we're going to be successful as a group in advanced alternative payment models, job satisfaction, and quite frankly, maintaining partners within the practice, we need to become more savvy and more intelligent about how we work with our colleagues. And it was with that in mind that we said, well, if we're going to do that, then let's reconfigure how nephrologists have worked with advanced practitioners. Let's see if we can challenge our advanced practitioners, let them challenge us, and see if we can actually make this a richer experience. So I'll tell you that we began, we've added advanced practitioner 1 or 2 for quite a long period of time, but it wasn't really until about 5 years ago when we said, we were down to 1 advanced practitioner, others had moved out of the area, but we said, I think it's time to bring in some other advanced practitioners to our practice. And so we said, let's try to think about this more creatively. So at that time, we had 1 nurse practitioner who had worked with our transplant and dialysis access surgeons. Forgive me for not mentioning it earlier, but our nephrology practice at this current time is about 9 nephrologists, 5 transplant surgeons who do a large majority of our vascular access work for transplant patients, dialysis patients, which really makes for a nice seamless provision of care for our patients. And now, as I said, we now have 5 advanced practitioners. And with that in mind, like I said, this nurse practitioner who was with us at the time was working with our surgeons. And she would primarily work in the office. She would do vein mapping. She would do pre- and post-operative care, whether it be for some transplant patients, but primarily for our dialysis access. And then she would also do some degree of rounding in a couple local dialysis units. And as I said, since that time, we've added on 1 other nurse practitioner and 3 physician assistants. And I'll share with you just in terms of how they're interacting with our group, what we're doing now, and then kind of take that to the next level of how we've tried to adapt within the confines of the pandemic. So what we ended up doing was actually asking two of our advanced practitioners to be involved in our hospital-based care. I think most of us who are involved in medicine kind of got our experience in the hospital. We did some practice and learning in clinic-based care, but I think a lot of it certainly occurs in the hospital. It's where a lot of the excitement is. I think it's where a lot of people who are coming out of training really want to see that kind of activity, and I think it turns into a rewarding experience on multiple different levels. So we work right now at a 715-bed tertiary care medical center where we provide kidney transplantation as well as all the other bells and whistles that tertiary care medical centers provide. And we already have one, now two, really nephrologists who are functioning really heavily as nephro hospitalists in the sense that they provide a great deal of their care here in the hospital and a far lesser degree in the clinic. And we said, I think it sure would be a good idea to actually intertwine some advanced practitioners with them. And what we've done over this period of time was that we started off with having our advanced practitioners manage the dialysis patients who came into the hospital. And then as we really kind of began to continue our educational endeavors and all, started taking on general nephrology consultative work for them as well. And what it's allowed them to do is actually participate in our team rounds with our fellows, with our students and residents, be part of the educational strategy, and really kind of expand that team model to a more broader level of care. And I'll say it's not only been, I believe, helpful to our advanced practitioners to learn not just from the nephrology attendings, but also from the fellows, but vice versa. And I got to say that a lot of our fellows, the feedback I've received from them has been that they feel that having someone else with them, like an advanced practitioner, has really taken some of the load off and allowed them to actually have a better training experience. And I think that's something which actually I'm hoping will also have benefits in terms of helping bring back some more interest, some more excitement in terms of our fellowship, and making sure we're bringing on new physicians. Mind you, my goal here is not necessarily to turn nephrology into an all-advanced practitioner or an all-physician workforce. I think we need to look at this as a bigger team approach, and I think that's where we can actually help each other succeed. So we're now actually advancing into the area of procedural work. We've had our advanced practitioners into the sim lab and learning sterile technique and all the things that are critical to being by the bedside. They're starting to take part in being involved with things like kidney biopsies and placement of central lines. And that's something that I hope to really expand upon in the not-too-distant future. They, of course, communicate wonderfully with inpatient as well as outpatient dialysis, charge nurses, really help improve our transitions of care, which if anyone has been involved with advanced alternative payment models, you have to realize that we're looking here at patient admissions, readmissions, prevention of admissions that are so critical. And our advanced practitioners are the first people to head down to the emergency department when that dialysis patient of ours drives right by their dialysis unit because they feel a little short of breath and says, I guess I better go to the emergency room. And we take a look at them and they're saturating okay, and they don't have wide-outed pulmonary edema. We'll say, let's see if we can actually safely get you back to your dialysis unit this morning. And it's that kind of interaction and support that the advanced practitioners have been able to provide us to really prevent a lot of unnecessary admissions to the hospital. And it just so happens that these two advanced practitioners who are working with us here, certainly incredibly compassionate people. They very much have grasped and appreciate the value of being able to speak of end of life and goals of care with family and patients. They're doing a wonderful job at it. We're working on becoming more integrated with the palliative care fellowship and group at our hospital. And again, I think it's really talking about real true closing of that circle of care for our patients I think that really kind of sums it up well. So they've really done a major job in terms of filling a lot of voids. And by being here in the hospital, when we receive a consult from a provider, particularly when they need timely care, they're there. And it's been remarkable in terms of the feedback I receive from hospitalists and other groups of people in terms of the fact that when a call goes out, a page goes out, they don't wait an hour or two to get a call back because the doctor's too busy in the office. They're getting timely care. They're learning and doing a wonderful job at managing the complexities of our dialysis patients. As I mentioned, interventions in the emergency room and preventing admissions and readmissions. Obviously we look at patients and do they really need blood transfusions or not? Those people who might go on to, be or are on a transplant list. And they've made many times, interventions that say, hold on a second, do we actually need to give this unit of blood today? And I think it's helped out dramatically for some of our folks. We now do a much better job with medication reconciliation and things that, quite frankly, a lot of us doctors just don't pay close enough attention to, and where these lapses, these dropped antibiotics, these misses that end up causing patients harm, quite frankly. We really don't see that problem like that anymore since we really adopted advanced practitioners. And again, it's that interaction with people that you just can't replace. And our advanced practitioners know every case manager by name. They know the hospitalist very well, and it really allows for us to be in the know, to anticipate when our patients are going to be discharged, to not surprise anybody, and to say, well, where did that come from? And that has made a dramatic difference in terms of really just trying to make sure we get our patients to the right dialysis unit, to the right places safely. Our other advanced practitioner that we've since hired has been working in local nursing homes and rehab facilities. Again, a really important place, as you can imagine, for helping prevent hospital readmissions. And then she also helps run our pre-dialysis advanced CKD outpatient clinic with one of our RNs in the office. And that's something that we'll really continue to kind of grow and build upon. Our fifth advanced practitioner is someone who's very interested in immunology and actually also has an interest in research as well. But he's really taken on a passion and taken on a role with one of our nephrologists in terms of managing our outpatient transplant clinic. So he takes care of a lot of our transplant clinic patients, and as you know, it's really a CKD clinic, but obviously with the management of immunosuppression and associated challenges with that. And then he also is somebody who's involved in our home dialysis program and joins me a couple times a month, and we round on see patients for their monthly home dialysis visits. And he's done a wonderful job in terms of really making a difference in terms of trying to help keep our patients safely home. As you know, patients and caregivers, fatigue is a common problem. These people need a ton of support, and he's done a wonderful job in terms of really helping bridge those gaps and helping our patients be happy. And that's, I think, the greatest success of all when it comes to home dialysis programs. So I think that, he said it's been a real fun thing to actually see everyone kind of grow into their roles. And yes, they all do take part to some degree in dialysis rounding, but it's a small part of their clinical time. They share rounds with a nephrologist. It's a team approach like in other areas, and so that they never feel like they necessarily have to be fully independent where they don't talk to their colleagues, their physician colleagues for weeks or months on end. That's just not how we want to run things. But at the same point, also give them the appropriate level of independence that they deserve. And to that end, I think we're seeing some successes. But in order to do that, I also feel it's critically important to also continue to engage them and to keep them satisfied. Again, from my perspective, part of my group's success is maintaining colleagues and who feel like they're valued members of the team. And we've developed a program for long-term learning whereby they meet once a week with one of my nephrology partners where they review cases and go through physiology. Some of our advanced practitioners, of course, as I mentioned earlier, are also very much integrated with the fellowship program in the sense that they're part of the daily rounds and in our conferences and lectures, and all of our advanced practitioners are encouraged to join in for those, which thanks to the pandemic, and hopefully beyond the pandemic, it's now something where we are going to keep things WebEx or whatever framework you wish to choose in terms of allowing people to not necessarily have to be here at the hospital, be part of education. Some of our advanced practitioners, as I mentioned earlier, are interested in some research, and they've participated in that and have been co-authored some papers with us over the years. And now I have two of our advanced practitioners who are very much interested in creating an advanced practitioner nephrology podcast. So that's something that's on its way into fruition. We're very excited about, very proud of them for wanting to put this together, and I think is going to be something that's going to be hopefully an opportunity to educate the advanced practitioner workforce out there, but also for patients and open people's eyes and minds to what advanced practitioners can do in nephrology. So this is kind of a schematic I put together that I think, generally speaking, hopefully kind of sums up the different opportunities and roles for advanced practitioners in nephrology. I hope and expect that as time goes on, these circles will continue to expand more. But I think right now it's, at the very least, fairly rich, robust, good experience for advanced practitioners. And it's, again, I think allowed them to feel that they truly are valued members of our team. So, with that all in mind, I thought, we talked a little bit about the advanced alternative payment models and how they've directly as well as indirectly had a major benefit to what we're trying to do with advancing American kidney health and all. But at the same point, they've also been incredibly valuable to us and to our patients as we've worked our way through the COVID-19 pandemic. And I'm sure I'm not alone in terms of saying that in the early days, there was, I think a lot of fear. We did not know what to expect. And quite frankly, for anyone who's been around long enough, you can also kind of think back to the days where HIV was first being discovered and how many people were fearful of things that, over time we realized we didn't need to be fearful of. But nevertheless, COVID-19 obviously we realize is a very unpredictable disease. It's been incredibly challenging to manage, but we've learned a lot as we've gone through this. And of course, early on, we were worried about were we going to knock out our workforce rapidly? We're going to have physicians, advanced practitioners, nurses available to provide dialysis or other care for our patients. And ultimately, concern became what was the most safe, most efficient way to actually take care of our patients and do so wisely. We knew that there's going to be a certain level of suffering, shall I say, in terms of how we're having to operate. We've all been through a lot this year, no question. But I think we tried to look forward and to say, if things go well, then we're happy with the way we approach things. If things don't, well, then at least have we kind of helped prepare our patients for what's to come. And to that end, we started out early on by having bulk of our advanced practitioners actually work remotely from home. And some are welcome to criticize that decision. But part of my rationale and thought was, and that of my partners, was that, again, we probably can't afford to have everyone out there all at once being at risk for getting sick. And maybe, just maybe, if we sit down and think about it and try to approach this with some semblance of calm and thoughtfulness, that we can actually make this work in our favor for our patients' care. And and as much as we were worried about our workforce, as I mentioned here, there was also a practicality of we need to space each other out. I mean, people couldn't just sit down at early on and eat lunch apart from each other. Where are people going to sit down to even have a conference or to talk about patients or to get their notes done? And that was hard, even for a big hospital. And of course, too, we didn't know if we were going to be looking at 90% of our patients hospitalized at some point or another, or were we going to be able to try to help mitigate that? And actually, by having our advanced practitioners working remotely early on, they played a major role in our in our area at least, and I think in terms of being successful in keeping our dialysis patients in their units and not ending up in the emergency rooms. So I do really attribute a great deal of our success to some of this strategy. And it's a busy slide, so I apologize. But early on, I mean, we, of course, as we always do, got to work early, and they did too. And, kids were running around the background on a few occasions, I remember, and different things, which was great. But we did our rounding virtually early on with some of us doctors here in the hospital. But by doing so, we could literally ask each other to say, please get this communicated for me right away. And quite frankly, some of the communication we were achieving at that early phase was probably better than we were doing before the pandemic at times, And in the setting of COVID, of course, we had to frequently change, whether it be on the inpatient side or the outpatient side, where our dialysis patients were going at any one point in time. We've always tried, very hard to keep our patients separated from each other and to make sure we had separate COVID shifts. At the hospital, we've never actually brought COVID positive patients into our dialysis unit. So all of our treatments occur off-site. And as most people on this call, I'm sure very much know, that puts an added strain on the nursing workforce, dialysis nursing workforce. And in order to help save them as best we could, we really needed to be thoughtful about how we provided dialysis and at the same point made sure we took good care of our patients. It was because of our advanced practitioners being able to actually really truly look from on high and look at the big picture for us. They were actually really able to help make that strategy work. And of course, from the point of view of discharging patients and getting COVID testing and everything, again, critically helpful in terms of working with the nursing staff. It was, again, a chaotic time, as we all know. But as patients left the hospital, we had to get them back to their quote-unquote clean units, or the PUI shifts where we were ruling out COVID, or to their COVID shifts. And it took a lot of work. And, but from that point of view, because they did such a good job at that, we did save ourselves a lot of unnecessary returns to the hospital. And rather than our hospital being overwhelmed with solely dialysis patients, which was a real fear that I had and something I conveyed to hospital leadership early on, because as oftentimes I think we all know, hospital leadership's great at ours has been at least in terms of managing the pandemic, but oftentimes our dialysis patients go overlooked, and it's not till we bring it up that they say, I forgot about that group of people, but thank you for doing that. And that was really what we had to do. We had to continuously bring this high-risk group to the fore to let the hospital administration know that this is a group of people for their sake, but also for the sake of other patients and our staff. We've got to think ahead and be very proactive. And we were able to do that because of the advanced practitioners. So the COVID triage continued to evolve. And our advanced practitioners actually created a nice detailed tracking system to keep tabs of our COVID positive patients in the hospital as well as outside the hospital to know where they are, how far along are they in their illness in terms of when can they quote unquote graduate and get back to their regular dialysis shifts safely. Their coordination with nursing staff inside outside the hospital was, to me, still probably the greatest game changer of all. And in their ability to provide transitions of care to our patients, to call our patients, to actually provide a real provider touch, in a sense, I think made a huge degree of difference in really helping these people recuperate and stay out of the hospital. And it's also allowed us to expand our telehealth services beyond the hospital setting to CKD clinics and transplant, and that's allowed us, I believe, today to actually have a semblance of, I think, a good deal of success. So, I think as I kind of come to a close here so we can take some questions and different things, but I think part of what led me to nephrology early on was the lure, quite frankly, of taking care of people who are ill. I think it's incredibly challenging, rewarding, and it's something that I think a lot of us truly embrace. And, yes, we do have challenges right now that we have to face up to. And I think in order to help sustain and even increase the nephrology workforce, which is really being required, we not only need to do things, I think, to actually help make sure that we're increasing energy, passion, interest in nephrology from a physician perspective, but we also really need to expand our minds and welcome in advanced practitioners more. And as I said earlier, I think in order to do so in a way that's not only respectful, but also thoughtful about how we actually build a more multi-talented, multi-disciplined group, I think we really need to give our advanced practitioners more to bite off and more challenges. And I hope I've shown you today, the folks we've had join us have taken on every single challenge we've offered them, and they have, obviously passed with flying colors and done a wonderful job for our patients. So, with that and the last piece here, one of the lessons and a slide I actually shared in an earlier talk was lessons I learned from our involvement in the ESCO, as well as what I've actually learned as well through the pandemic. But I think in order to be successful, in order to provide better value-based care, we need to do a lot of things in nephrology. We need to do a lot of them a lot better, and we really need to get our act together here. And that's what, as a group, we've been trying to work on in terms of creating more creativity for home support, as well as vascular access support, which I mentioned, because our surgical colleagues, I think, have been wonderful for us. But I think beyond that, and transitions of care and other areas, the value of advanced practitioners is a home run, in my opinion, and something that I think is really an incredibly bright future, not just for advanced practitioners, but for the field of nephrology. And the last thing I have here is just this Team of Teams, which is a beautiful, well-written book by Stanley McChrystal, and where it really talks about a need to adapt. We need to be more adaptable, more flexible in all areas of medicine. And I think we absolutely can apply that to where we are here today in the COVID pandemic. And advanced practitioners have allowed us to do that. So that's with that being said, I think that's the end of my talk. And I want to thank everyone for listening. And I certainly want to give a thank you to our advanced practitioners in my group who have really made this a success story.
Great. Thank you, Dr. Landry. Just a reminder to the participants, if you have any questions for Doctor, please submit them into the chat or Q&A. We do have a few minutes here left to ask a couple questions, and I do see some that came in. So Danny asks, are medical schools or / advanced practice programs being notified of this data and this need? Perhaps if they were more aware and knowledgeable about this shortage, they could include more nephrology training and exposure in their curriculum.
Yeah, I couldn't agree more. And there's a couple areas I'm kind of actively working on right now. One is I'm looking to get actually our experience published so we can actually get this out further throughout the country, throughout the world, I hope. And secondly, we actually have 3, I think even maybe 4th coming soon, advanced practitioner programs in our area alone. I know they're exploding, and we've actually taken a role in proactively where we're actually involved with an educational program. So, I think it's actually something that I would encourage every nephrology group out there, whether you're involved in education with residents or fellows or not, I think to look around your area to see if there's an advanced practitioner school, because they're oftentimes looking for people to come by, give a few lectures. It's a great opportunity to really help people connect.
Great, thank you. This may kind of lead into my next question here. It says, what can I do as a nurse, as a manager of a dialysis facility, to get the nephrology practice that I work with to hire an advanced practitioner?
Yeah, I love the question. I truly do, because I look around and I feel the same way. And I'll say this, that I realize there's a bit of hesitancy on the part of some people. Because like a lot of things, I think in order to see something really come to fruition, you have to invest, right? And you have to invest. It's financial resources. It's time. I'll be honest with you, the financial resources are maybe not small, but honestly, the time commitment and the effort is even greater, but well worth it. And I think from my point of view, it's really a bit of And some people, I think, either getting them to read and understand more about it, but at the same point too, part of the problem out there is that if you go out there and Google or do a Medscape search or something, you won't find much of anything, right? Little of anything out there in terms of advanced practitioners in the nephrology workforce. That what I just showed you in terms of that survey was really one of the major pieces, and I think it's beholden to us to really kind of get the word out. I think as a clinic manager, my personal take is I think to hopefully share with them some of the thoughts and ideas that you've heard today, because at the end of the day, I just feel that too often we in nephrology are not really sharing the workload in a wise way. And I think we find ourselves doing things that really could have other people helping us with. And I think that's really it's something that hopefully catches some people's attention in terms of saying, could I actually work smarter? And this is what advanced practitioners allow us to do.
Great, thank you. Actually, here's a comment I'll just share with everybody from Pamela. It says, thank you so much. Love your support and vision of the advanced practitioners in dialysis. So thank you, Pamela, for that. Question here, it says, have you done any internship with nurse practitioners? They are always looking for clinical rotation sites, and this experience often leads to hiring of the individual.
Yes, and yes, and yes. Absolutely. That's part of what we have done over the last several years is not only come out to the advanced practitioner classrooms to teach, but to encourage, and again, having your face out there, right? I think if you're a dedicated person who likes to teach, enjoys that kind of thing, people want to work with you too. And I think it's given us a lot of opportunities where we've had people come to us and say, could I have a month? Could I to come and work with you? And it's been a lot of fun because whereas I think in a lot of different areas, while I think it's great that advanced practitioner students get to work with the fellows and the residents, but I think it's also really wonderful to have them work with nephrology trained advanced practitioners. So they actually get to see what life's really like. So yes, we are doing that, and it's something I would absolutely encourage other people to think about too.
Good, great, thank you. Another question, what kind of feedback have you received from the dialysis facilities since you have incorporated the APs in your practice?
Yeah, a wonderful question. I will say that I'd be challenged to find a negative to give you, and I'd be more than happy to share it with you if I did. But what advanced practitioners have allowed us to do, as I said, is, again, please don't misunderstand me. This is not about saying, well, I'll give the scut work off the advanced practitioner. I think we work together as a team very well, and a lot of the work we do is fairly, it's the same with a lot of our patients. But what I've heard from our dialysis units is, again, much like in the hospital setting from the ER attendings or the hospitalists, is that the timeliness of response is better, that the clarity in the documentation that we need is better. And again, that doesn't happen just by mistake. You've got to be willing to work with advanced practitioners, and they've got to be willing to work with you to show, here's our expectations, here's what we're looking to provide, here's a general framework that I want you to kind of initially learn off of, but then to make it your own, because these people are, so incredibly bright and talented that it's, again, I've learned a lot more from them, I'm sure, than they've learned from me.
Right. Okay. But yeah, we have time for probably one or two more. Another question comes in. It says, do the duties of a AP differ from the state to state?
Yes, and the answer appears to be yes. While I know that there's many different states who are trying to come on board with others, there are different things that in every state you certainly do need to query and to look into. And as most of you probably know, that can also differ between nurse practitioner versus advanced physician assistant. And so you do have to be aware of that, because whether it be an issue of level of oversight as well as the type of billing that you can perform. So I do encourage everyone just to be aware of that, but nevertheless, I would say that regardless of the rules in your state, you can definitely make this process work and work very effectively.
Okay, thank you. Question just came in. Have you seen improved quality care with the addition of the APRN in hemodialysis nephrology units?
Yes, and while my take on that is one that is not heavily data-driven at this point in time. That's kind of the next step that we're looking to kind of move our way into. But that being said, I can say from the feedback that I've received, kind of going along with the question mentioned earlier from our dialysis nurse managers, as well as from some of the other leaders in the nephrology organizations and dialysis organizations, I should say, as well as the outcomes that we witnessed through our seamless care organization, that I believe that yes, they've played a major role in terms of the quality care. And again, the main focuses that have really been driving expense have been hospitalizations and returning to the hospital and these transitions of care. And that's where I've tried to help manage that as best we could.
All right. Well, I think I'm just going to do this one closing comment and then we'll wrap up. It says, since our MD attending group brought in AP to help follow and round in both outpatient programs, we have found that we have had improved outcomes, which is a plus. And just one more thing, shout out to you. Thank you, Dr. Landry, for the enlightening and entertaining presentation. So next slide. I think we'll go ahead and wrap up. For today's presentation, I just want to remind everybody on the ESRD NCC has a flu vaccination toolkit. It includes all kinds of features like flu facts and taglines, social media content you can use, flu videos, a lot of print-ready material, on-demand training and educational events you can find. So please visit the esrdncc.org /flu and get some more information about the flu vaccine. Next slide. And then just as a reminder, we do have inspirational posters available. They are 12 by 18 posters. These can be printed and displayed in your dialysis facility or within your organization. They focus on psychological and physical health, emergency preparedness, and COVID-19. So again, visit our website down there listed below to get access to any of these inspirational posters. Next slide. And our kidney, shout out to our kidney hub. This is a mobile-friendly web tool created by patients for patients. There are lots of links to new videos and resources are continually being added to this hub. As you can see below, we've got home dialysis, there's COVID-19 resources, transplant, and the diet and nutritional resources have recently been added also. Next slide. So just our next COVID-19 webinar events, we have the patient-focused event on February 16th at 4 p.m. and our next provider-focused event will be February 24th at 3 p.m. We hope to see you at one of those events. You can register. Those events are posted on our website, and you can go ahead and visit covidinfocenter.com to register for those. Next slide. And just wrapping up, I just want to thank again Dr. Landry for taking time out of his day to do the presentation. We really appreciate it. And I just thank you for everybody to taking time out of your busy days also to spend with us. So thank you very much. Enjoy the rest of your day and stay safe. Thank you, everybody. Bye-bye.